Thank you everybody. Thank you RSSTI. What I'm going to talk in next 20 minutes would be more or less clinical talk. We all know about this pandemic. Diabetic patients have been disproportionately affected because of COVID. As we all know, during first wave in UK alone, 14,000 patients died in first 4 months, which was 1/3 of all total deaths. 12 to 25% patients having COVID had diabetes, suggesting a very huge association between diabetes and mortality during COVID. We all know these risk factors. People with these conditions were at risk of severe COVID, hypertension, diabetes, CKD. So, severe COVID seems to be affecting people with cardiometabolic conditions. Simultaneously, COVID being a pro-inflammatory disease, it also produces cardiometabolic condition. These were the challenges that we faced during COVID era. More burden on patients and physicians. It was very difficult for physicians to manage hypo and hyper, just like walking on an edge of a sword. Accessibility to manpower for patients and for physician was very low. Same was the accessibility to medicines, accessibility to diagnostic tools, and point of care instruments were not available. As far as the patients were concerned, there was inadequate fluid intake, inadequate food intake, thanks to COVID itself, volume depletion, which was dangerous in any patients having diabetes. Drug-induced GI symptoms. Many of the drugs which we used during COVID produce anorexia, vomiting, or diarrhea. Fever itself was a fluid-losing entity. Patients started stopping drug for diabetes. Steroid-induced hyperglycemia was an issue, and there was a definite ketotic milieu. Hypoglycemia, unawareness, nuclear families, lack of manpower, lack of resources, and failure to get help, which was regularly available. Even the neighbors stopped moving into the neighbor's house because of fear of COVID. So, the resources that were routinely available to an elderly male, 70 years old, were also not available during COVID. How did we manage? We tried to manage it with 3 levels of tele management: teleconsultation, telemonitoring, and then remote patient monitoring systems. But this is not going to work. It might have worked during COVID, but this is not going to work in next 6 months or 1 year once the COVID is over. So, the way in which we managed diabetes was this. We managed COVID with diabetes in this algorithm, but these algorithms are now out. What was the impact of this pandemic? Very important. Unless we know the impact of this pandemic, we are not going to realize what damage it has done. During pandemic, diabetic services have been interrupted for the patients. So patients who are ready to go to marriages now, who are ready to go to the funerals now, who are ready to go to the election meetings now, but they are afraid of going to a doctor. They are shielding, isolating themselves because they are clinically vulnerable. They believe that going to a doctor, I'll expose myself to COVID. There has been a social distancing measures only as far as a hospital is concerned. The suspension of routine appointments and redeployment of healthcare staff. Reduction in new diagnosis of diabetes by about 70% as compared to previous year. These are the figures of 2 hospitals in Mumbai, where the diagnosis of diabetes is less by 70% because the patients are not undergoing investigation. HbA1c testing monitoring in people with diabetes has reduced by 77 to 84%. These are the figures from 2 important hospitals, 2 corporate hospitals from Delhi, which suggests that the HbA1c measurement itself has gone down by 77% to 84% during last 6 months. And the care processes, retinopathy, FEET, checking blood pressure, HbA1c check and lipid check, everything is down by 20 to 58%. More importantly, we all know the importance of delay in the diagnosis of diabetes, delay in reaching the targets. We all know that a 1 year delay in reaching the target HbA1c produces increased risk of myocardial infarction, increased risk of heart failure, stroke, and composite cardiovascular events. What is happening? We are going to see 18 months of delay, bare minimum, maybe 24 months of delay in developing countries of achieving target HbA1c. So, how are we going to manage diabetes in post-COVID era? People are failing to seek help. People are failing to attend hospitals, neglecting symptoms of other diseases. If they are having hernia, they are not reaching the hospital. They are delaying the surgeries for cataract. All diabetic patients are avoiding surgeries, and that is causing problem. Not only that, a diabetic patient admitted to a hospital has to undergo certain COVID protocol, and that delays many procedures. Could it be angioplasty, it could be CABG, or it could be any other surgeries. Collectively, it has been estimated that impact on cardiology services has been the highest of all, followed by the surgical procedures. The overall physical and mental health of patient has already been discussed, has been at a very low. Even if they've encountered COVID or they've not encountered COVID, anxiety is at the best. Readmissions. Readmission rate is highest among patients with diabetes. Around 10 to 30% of people die in hospital and 30% get readmitted within 140 days. So, the new challenges are sudden onset of pandemic, protocols which were created for management of diabetes during COVID did not have robust evidences. So it is time to sit down and start thinking about evidence-based medicine rather than experience-based medicine that we all saw during pandemic, especially in India and Southeast Asia. What are the definitive evidences? Diabetes and cardiovascular disease are major risk factors without any doubt. Rates of severe disease and mortality during pandemic elevated in patients with diabetes as compared to non-diabetic people, absolutely certain. Long-term control is a risk factor, as is hyperglycemia itself. So, sugar levels at the time of admission and HbA1c level uncontrolled, both were high risk for COVID. Advanced stage systemic inflammation in obesity, hypertension, coronary artery disease, and CKD. So, another hypothesis is ongoing inflammation after resolution of COVID. We do not know at present how long the inflammation persists, especially the pulmonary inflammation. So the first priority is risk stratification tools. Start identifying your diabetic patients and divide them into the people, diabetic people having highest risk. How can you do it? There is a very nice ABCD risk stratification post-COVID. Remember, this is post-COVID. Association of British Cardiologists, Consulting Diabetologists have come out, try to identify these 8 groups of patients and target them first. And that should be the first important lesson that we should learn. This is an opportunity. Take it as an opportunity to achieve normoglycemia, which could not be achieved in pre-COVID era. You may not have been able to use probably SGLT2 inhibitors or GLP-1 receptor agonists pre-COVID era. So start using this as an opportunity to shift to newer drugs only wherever it is indicated, not without indication. But this is a time when diabetic patients are going to happily accept the newer drugs. COVID fear may allow the battery of investigations in diabetic patients who reach to you. So, the cardiovascular assessment and renal assessment may be safely done now because the patients are now more open to investigation and treatment. And therefore, explaining them the cardiorenal benefits that the newer drugs are giving would be proper timing. Unfortunately, the biggest issue is it is difficult to realize whether the patient has really recovered from COVID-19 or not. Pulmonary status is certainly not known. The HbA1c levels are fluctuating. There are not so robust evidences on restarting of the drugs and potential impact of clinical inertia. There are limited evidences about de-intensification of insulin that we started during COVID. So how do you de-intensify the insulin that was started during COVID in patients, especially who were on steroids? And the only answer is follow the discharge protocols that were being done during pre-COVID era. And that's how you can reduce and gradually stop the insulin in this patient. Prevention of diabetes, induction of type 2 diabetes remission, effective treatment to prevent complications, and monitoring, they all should continue. Target the comorbidities and open the minds of physicians for all-rounder drugs. Annual review should become very, very important. One-stop shop. Wherever possible, try to send the patient to a place where all investigations can be done under one roof. So, the clinical tips. How shall we manage diabetes during post-COVID era? Start using point-of-care instruments more frequently. Use technological advances like CGMS. Promoting SMPG was never so important in the history of medicine. Explain to the patient to have a glucose meter and use SMPG more frequently, even if he is not on insulin in type 2 diabetes. And these are the bare minimum things that the patient should have, a patient of diabetes, at his home for next 1 year till we say absolutely bye-bye to COVID. Till we are afraid that COVID can come back or any such endemicity may be converted into epidemicity, these things should be there with the patient. Confirm it. All your diabetic patients should have digital blood pressure instrument at home, keto sticks at home, glucose meter, oximeter, PEFR. Just we heard a very nice talk on pulmonology. So peak expiratory flow rate, there is a measurement, PEFM. It's a very simple instrument, should be there with all patients, especially having pulmonary conditions with diabetes. Glucose tablets, because hypoglycemia could be more frequent. Access to paramedics, access to online ECG, and lab contact numbers. We must instruct all our diabetic patients to have all these facilities. Retinal and food screening not done within last 18 months must be immediately carried out. Most of the patients are away from retinal and food screening, which was not possible online. So this should be immediately done for the patients who have not undergone these things in last 18 months. We need to continue outpatient urgent acute diabetes care, control of glycemia, detection of comorbidities, and control of comorbidities. Lifestyle changes, they were never so important. There is diet explosion. People are away from restaurants, people are away from junk foods for 18 months. So they are going to attack the restaurants and they are going to start eating anything and everything that they could not eat within 18 months. Our diabetic patients must be cautioned against this diet explosion and continue to follow the diet restrictions which are necessary. Alcohol slavery and smoking. People were away from these two menaces in last 18 months. Encourage them to stop them. If they can remain without these things for a few months, they can remain without them for lifelong. So this is an opportunity to de-addict people. And exercise. In a very small house of 16 by 16, people could not exercise. So encourage them to exercise, show them the ways and means of exercise. Emphasize on compliance. As far as the selection of pharmacotherapy is concerned, we need to select pharmacotherapy in two ways. First, we need to find out which pharmacotherapy is safe during COVID if it comes back, and then which pharmacotherapy is beneficial in COVID if it comes back. The answer is none. Almost all pharmacotherapies are safe as far as the COVID is concerned, but we must give significance to statins. People should not stop taking statins. ACE/ARB anticoagulants as and when needed. Avoid prolonged use of steroids. Stop them at the earliest and think about opportunistic infection, especially like mucor. Lots of studies are going on. to find out whether any pharmacotherapy for diabetes is beneficial. We used to say during the beginning of COVID epidemic that SGLT2 inhibitors required to be stopped and we require to continue with gliptins. But now there are lots of studies like this which suggest that most of the pharmacotherapy during COVID, unless the patient is in critical care unit, is absolutely safe. It is only critical care unit where you require insulin. Otherwise, you can continue. Lots of studies have come out. And one of them is DARE-19 study, which has come out and suggested that SGLT2 inhibitor in a diabetic patient during COVID is safe unless the patient has lost appetite, is vomiting, or is in a critical care unit. Of course, they wanted to prove that they are beneficial, but they have not been able to prove it. It's still not clear whether any glucose lowering agent provide any protection from COVID. Lots of claims have been made, but not a single group of drugs have proved to be giving protection. The favoring insulin in hospitalized patients, but now many studies have come which suggested that outside an intensive care unit in a hospital, insulin is of no additional benefit. So you can continue with OHA outside critical care setting. In fact, there are trials which suggest fixed ratio formulations like GLP-1 receptor agonist or SGLT2 inhibitor with basal insulins. They fare much better than insulin alone. Of course, outside critical care unit. In a critical care unit, there cannot be any other drug except for insulin. This is how we require to manage contact with HCP, telecare, face-to-face for urgent pediatric and ophthalmologic high-risk pregnancy. These are the places or these are the patients which we should target first. Important thing is health education, as has been rightly suggested at the lower bottom. Patient education, clear point of contact, all these things are becoming very, very important. A couple of slides about new onset diabetes. Now we know two important trials have suggested that diabetes can develop in COVID or because of COVID, because of infected beta cells. In addition to the loss of beta cells, the infection also appears to change the fate of surviving cells. Not only that, beta cells undergo a transdifferentiation, and all these things lead to the COVID-induced diabetes, and therefore the most important recommendation that was recently given was screening for diabetes takes priority at an early age of 25 post-COVID. Patients, those who suffered from COVID, must undergo diabetes screening even at the age of 25. And we are finding lots of such patients. And last but not the least, COVID vaccine everybody is taking. But do not forget to vaccinate all your patients with 3 important vaccines. Influenza vaccine, that is very important. Pneumococcal vaccine, 1 dose before 65 and 1 dose after 65, very important. And the rest of the vaccination as per the suggestion. But 2 important vaccines, influenza and pneumococcal, if your diabetic patient has not taken, must be given. So concluding, now more than forever is the time for expert advocacy for previously unpalatable societal measures. Individually targeted evidence-based health promotion is required. Lifestyle changes must be explained to the patient. Use post-COVID era as an opportunity to improve diabetes care at the level of community and at the level of individual. Thank you very much.